Okay, good afternoon. It's a very hot afternoon in Joburg. So we all assume sounds quite good at this point in time. But thank you for joining us. So today, for those of you that haven't been with us before, I'm Bettina Moser. I'm a pelvic physio and I am a trauma-informed and integrative life coach. So but today we are specifically talking about a more pelvic physio related topic. And I welcome my colleague Hester van Aswegen. And Hester, you can just introduce yourself, and I'm sure most of the audience knows you very well. They probably know you better than me because I've been having babies and doing lots of other things, and I haven't had my my time in the pelvic physio side for the last while as much as I used to. So I'm sure everyone knows you, but please, if you can just say hi and introduce yourself, and then Hester's gonna be off with her topic on constipation. So for those of you that are not familiar with this, please pop your questions into the Q&As for me. I will pick them up, and then we'll stop periodically, or we'll take time at the end, however it feels best for you. Hester, you'll guide that process, and then we can and I invite you really to ask lots of questions, because that's how we can integrate everything and put it into a more practical format that makes more sense for us to take away with. So Hester, I'll hand over to you. Thank you.
Hi everybody, I'm Hester van Aswegen. I'm also a pelvic floor physio. Tina and I have been working together for a number of years. And it's nice to be here with you this afternoon and to discuss a topic around constipation, I think, which is something that we really deal a lot with as part of our pelvic practices. So I'm going to just start sharing my screen, and I just want to check that everybody can see. Just indicate to me that you can see. Is that good, Bettina?
I can see. Thanks, Hester.
Perfect. Okay. Right. So let's get going. I'm going to chat a little bit about the background, what we deal with, what we see, and what are the simple things that we can try and do to try and help improve this problem. As Bettina said, if you've got questions, please pop it into the chats, and then maybe 2 or 3 times throughout the talk, I'm going to stop and we can look at some of the questions and chat further about that. The question time is also always nice because we really get to see what other people are dealing with and just learn a lot from one another. So if we look at constipation, when I started out as a pelvic floor physio, I never really thought that this would be one of the things that one deals with such a lot. And I must say, as part of our pelvic practices, I think just about every one of my patients struggle a little bit with some form of constipation or bowel dysfunction. It really is a huge contributing factor to many of the pelvic problems that we see. So whether patients come into the rooms with pelvic pain or a prolapse, so many of them actually have some trouble with their bowel. So it's really a part that we spend quite a lot of time on to try and help people sort this out. So let's look a little bit at what we deal with. And I thought that I'll give you a little bit of background, show you some pictures to understand the anatomy behind all of this. So firstly, I think it's important to just look at the gastrointestinal tract and realize that it's the tract that goes from the mouth to the anus, and in between we've got all the organs of the digestive system. So you've got the mouth, the esophagus, then the stomach, and then that goes into the intestines. The lower gastrointestinal tract consists of 2 segments. So either the small intestines, which is that bit there in the middle that you can see, all those little loopy bits. And then there's the large intestine, or the colon, on the outside of the abdominal wall. And we can see the ascending colon going up. And if you think about your own body, it goes up the right side, so more or less from the right hip bone here in front, up to under your rib cage. Then the transverse colon goes across, and then the descending colon lies on the left side of your stomach area. And that eventually ends up in the rectum here at the end, which goes over into the anal canal. And the rectum area is the area where stool is stored. So food moves from the stomach into the intestine and gets digested, and eventually as it reaches the colon and it moves across ascending, transverse, and then into the descending colon, water is absorbed from the stool, making it a little bit more firmer. And once there's enough stool in the rectum, you are going to get a message to say rectum is full, you now need to go to the toilet. And then we need to be able to pass that stool. So that just gives you an idea of how stool and food moves through the digestive tract. One of the things that we can think about is how much time does it take for food to move through? And for some people, they've got a bit of a slower digestive tract and it can take a bit more time. Others, it's a bit faster, but the average normal should be anything between 24 to 48 hours. So it can be 1 to 2 days that food moves through the gut and through the system before we pass a stool. So that just makes us think about what is constipation. And maybe I must just quickly, I actually have a little bit of, I'm going to show you the definition just now, and then we'll talk about what it means if you're constipated or if you're struggling. Let's just first try and understand the rest of the anatomy. So this picture just shows you the pelvic organs that lie in the pelvic bowl. And if you look at this person, it's a her, she's lying on her back. And here you can see the pubic symphysis there at the top. So there, that would be the pubic region, and your abdominal area just up here. In this pelvic bowl lies your bladder in the front there with the urethra. Then behind that is the vagina, and the uterus sort of lies over the bladder area with your fallopian tubes and ovaries there. And then at the back, we've got the rectum and the anal opening. Here, right at the back is the bony bit. So that's the sacrum that you see coming down there into the coccyx area. And your pelvic floor muscle is this muscle that stretches from your pubic symphysis in front right through all the way to the coccyx at the back. And I'm sure if you are patients in our practice, you'll know that we talk quite a lot about the pelvic floor, and we're going to chat about how the pelvic floor affects bowel dysfunction or constipation a little bit later on. So that just gives you a nice idea of the anatomy of the pelvic organs. So here we look at those pelvic floor muscles. And I just thought I'd do a little bit of revision that you understand when I talk about the exercises, what we're looking at. On this picture on the left, you can see the deeper layer of the pelvic floor muscles and how they stretch from the front, which is there, the pubic symphysis area, coming down that bony ridge, and they sort of loop around. Your anal opening is going to be here and the bladder vagina just in front, but they loop around, coming back to the other side, all the way like that. At the back, you can see how it links up to attach to the coccyx there. And then you've also got these other muscles running from the side wall of the pelvis to the midline to the coccyx there. Here at the back, you can see the deeper layer of muscles, which are hip rotators and the glutes behind them. So that's the deeper layer of your pelvic floor muscles. And we're looking from the top, so the stomach down onto that area. Here on the right-hand side, we see the superficial layer of muscles. So this is the muscles, the layer that contains the sphincters. And in this case, you're looking from the bottom, so from the legs into the pelvic region onto the perineum. And you can see the muscles here. So the openings are bladder opening in front, vaginal opening behind that. And around that, we've got a sphincter that we call the bulbocavernosus or bulbospongiosus. Here in the midline, we've got the perineal body, which is a supportive structure. And then at the back, we've got the anal opening with the external anal sphincter there. And these other little triangular muscles are also part of your superficial pelvic floor. So we think about the function of these muscles. Remember that your sphincters are the muscles that have to be able to close around the openings to prevent you from leaking. And they also obviously play a supportive role together with the rest of the muscle group. These same sphincters have to be able to open to allow you to either empty your bladder or empty your bowel. And that's quite important. We're going to chat a lot about that ability, because if we struggle, if there's tension, then you potentially can have a problem with emptying your bowels well. Obviously, the pelvic floor also plays a role to support those pelvic organs that we looked at a little bit earlier. And then we know that the pelvic floor is part of our core muscles. So together with the diaphragm, the abdominals, the lower back muscles, your pelvic floor is important in supporting and allowing your body to move well. So our pelvic areas is a big base of support. And if we have got a weakness or a dysfunction in that area, it will also affect our ability to move well. And it can also negatively impact the other functions of the pelvic floor. So we'll chat a little bit more about that. One of the muscles I think that relates especially to anorectal dysfunction is the puborectalis muscle. So puborectalis is just part of the pelvic floor. And if you look at this picture on the left-hand side, you can see puborectalis slings around the anus there. So this is the rectum, the colon lies up there, the rectum comes down, there's your anal canal. And remember that the anal canal is about 3 to 4 centimeters long and it ends in the anal opening there. Puborectalis is that part of the pelvic floor that slings from the pubic symphysis in front around that anus and back to the other side to kink it. And that's an important part of our continence mechanism. In other words, it helps us not to leak. So it supports around that area and prevents us from leaking. Here on the right-hand side, you can see in the sitting position, puborectalis really kinks that area below the rectum. When we go into a squat, the muscle relaxes, and that's really important. So when we go and sit on the toilet to pass the stool, puborectalis needs to be able to relax well so that we can empty properly. And if puborectalis is a problem, if it's too tight, it's not relaxing well, that can really play a big role why we struggle with emptying our bowels. And we'll look at the sitting position a little bit later. So just remember this, we are going to refer back to that later on. So what is normal in terms of a bowel movement? And what do we define as constipation? So on average, people accept that we should go to the toilet maybe once a day. Most people feel comfortable with that, but normal can really vary. It could be anything between once a day, 3 times a week, and sometimes people only will also go 3 times a day. So it's not to say it should be this, but it's within that variation of either somewhere between 3 times a week and then maybe even 3 times a day. But that's not the only thing that defines normal bowel function. We should make sure that our stools are not too hard or too soft, and I'll show you on the Bristol stools chart what that looks like. So we prefer that nice soft sausage because that should be easy to pass. Then we should also be able to pass that stool without straining. We shouldn't have pain, they shouldn't be bleeding, and we should be able to empty well. So if there's a problem with any of those things, that could mean that we have constipation. In most cases, constipation, obviously, there's a lot of contributing factors, but often it could be that, I think the 2 of the main things that we see is that we've got a pelvic floor problem. In other words, those muscles, that puborectalis that we talked about, is not relaxing well enough, and therefore we struggle to empty. Or it might mean that we've got a gut problem. So if there's something wrong in your digestive tract in the form of a disease, or things are just really slow, that's going to contribute to maybe developing difficulty in passing stool. So we'll discuss, I'm going to show you some of the other components that can have an effect as well, but those are often the main things that we see. And I think one must just remember that there's many things that can actually affect that transit time and the time that the food takes to move through the digestive system. And some of the common ones are things like stress, dehydration, in other words, if we're not drinking enough water especially. Alcohol can be negative, rich food, changes in routines, time spent away from home. So we must remember that our bowels like routine. They often like to empty in the same place at the same time every day. So if you go traveling and if you experiences experience things in your day that upset the routine a little bit, then it can play havoc with your bowels, especially if you tend to be one of those people that have a bit of constipation. One of my patients described themselves as being a cement mixer. They've got a cement mixer. And I always find that I think it's quite a good description of what happens in your gut. Things are just a little bit slow. So let's look at the various factors that can play a role. I think we should also define or just understand that there's differences between IBS and obstructive defecation and then constipation as such. You know, we tend to use the term quite loosely, but what does it really mean? Constipation is that difficulty in passing stools where your stool is too hard, you have difficulty with emptying, and you tend to strain quite a lot. People with IBS can have a picture of constipation. So they generally have pain with passing stool, but then their stools can vary, and it could sometimes be quite constipated, and sometimes they might have diarrhea. And the other type of problems that they often experience is bloating and distension, and they really can feel quite a lot of discomfort in the abdominal region especially. So just remember that a lot of people are diagnosed, or the doctors tell them that they struggle with IBS, and IBS then generally means that they've got pain or discomfort and bloating, together with that picture of alternating diarrhea and constipation. The other terminology that we often come across is obstructive defecation, and that really means that it's the difficulty in passing a stool or emptying the rectum, even though, and you keep on going back to the toilet because you are not emptying properly. And the problem generally lies with your pelvic floor or the anal opening area that's really just not relaxing well enough. So that puborectalis muscle that I talked about earlier on can really be a problem here. So it's actually a form of constipation. And I think it's just important to realize the difference between the two. Obstructive defecation is often caused by things like a structural abnormality. If you've got a prolapse, like a rectocele, which means that the rectum is bulging into that vaginal space, and it almost covers the opening of the anus, you're going to have trouble passing that stool. But it could also be the inability of the muscles to relax well enough. And therefore you get the urge, you feel that you want to go and sit on the toilet, but nothing really happens, and then you start straining. So there's just a little bit of a difference. I think that's good to understand. Right, so what should our stools look like? The Bristol stool chart shows it very nicely. And you can see on here that it can vary anything between type 1 stool, which is those large little lumps. In Afrikaans, we say boktrolletjies. And that you can imagine if your stool is like that, that you're going to struggle. So that's typically the person who's really constipated and struggling to pass a stool. Because the reason why the stool is so hard there is because water has been drawn out of it in your colon. So if your stool has spent a long time in the colon, it becomes harder and harder and eventually lands up looking like that. Then type 2 and 3 are formed stools, so still pretty lumpy. And type 2 can be lumpy and sausage-like, can be quite a big stool. And that's often also somebody who struggles to get rid of that stool. Type 3 is slightly softer, but still cracks in the surface. And that could be regarded as normal if you don't need to strain to pass that and you're emptying okay. But type 4 is the one that we prefer, that nice little soft sausage. You know, if your stool looks like that, you pass it, you shouldn't need to strain, it shouldn't be difficult, you should empty well. So that's really the one that we want to aim for all the time. When we go to type 5, 6, and 7, it becomes your more looser stools. So type 5 is those soft blobs with clear-cut edges. Type 6 is a mushy consistency, so it's starting to get more and more fluid-like. And then type 7 is total diarrhea, where it's just a liquid consistency with no solid pieces. So in general, if one is constipated, you will have stools that look like type 1 and type 2. 3 and 4 is regarded as normal. And these others, you do want to think about why they are slightly looser than we'd like to see. Obviously, type 7 is when you generally have diarrhea or you're sick. I thought I'll show you this X-ray just to give you an idea. So if you look at the X-ray taken, it's an abdominal X-ray, and you can actually see here on the left-hand side that person's colon is really full of stool, and the stool is backed up all the way, and you can really see how the colon runs there quite nicely. But can you see that there's a lot of stool sitting in the colon? So this person is really backed up, because normally we will only have stool here in the last part into the rectum and maybe a little bit along the descending colon. And this person is really backed up all the way into the ascending colon. And then here on the right-hand side, you see a similar picture. So loads of stool sitting in those regions. And sometimes you can even see how it doesn't show it very clearly here, but if the rectum becomes very distended, we call it a megarectum, because if stool keeps on moving in there and keeps on moving in there, and that's the pattern overall, that poor rectum really gets stretched more than it should, and it can become quite distended, which is also then going to affect your ability to empty properly. So that just shows you what it looks like on an X-ray. So let's think about the causes and what's the contributing factors that can cause us to be constipated. And it can vary quite a lot. It could be simple lifestyle things. So very often we find that we're not drinking enough. And I think that's a major contributing factor, that people really do not drink enough water. And if they drink, there are some people that really drink no water, and some prefer to drink other fluids like coffee and tea and cold drinks and even fruit juice. And I think we must just realize that our bodies prefer water. The moment you start adding stuff into fluid, whether it's milk and sugar and all sorts of other things, it's a little bit more difficult to digest. And if you have a sensitive digestive system, you might struggle with that. A lot of other things that we drink, like, I mean, if you think about soda drinks, they're loaded with sugar. That's not necessarily good for your system. They contain preservatives and colorants that could be difficult. So we should really consider fluid. And there's a lot of questions always about what is normal and what is not, and how much fluid should one drink. And I think there's one or two averages. One of the formulas is to say you should have, if you look at your weight, so let's say you weigh 60 kgs and you divide that by 10, that'll give you about 6 glasses of water a day. And there's another formula that says you should drink 30 mils of water per kg. So you can work that out. I think 6 to 8 is the average that we would look at. And some people are fine with less, but if your stool is too hard, one would probably advise that you really think about drinking more fluid. So just keep that in mind. It's such a simple thing, but often something that we really, I don't know if people just forget or they don't like water, and there's many other reasons. Fluid is one of the things we should really consider. Then diet is a big component, and we're going to talk about diet. I've got some other slides on food, so I'm not going to elaborate on that now, but let's just look at the other causes. Diet, then medication, and we also have a slide on that. Different medicines that you drink can really affect your bowel and slow down your system quite a lot. Things like pregnancy, when you have loads of hormonal changes going on and babies pressing on the colon, that can definitely affect how your gut works. Stress is a biggie. We'll talk a little bit about stress later on as well, but it can really play havoc with your gut and how it functions. I've mentioned the change of scenery and traveling. Your gut doesn't like it if you go away from where it likes to pass a stool and where it feels comfortable. As we get older, unfortunately, our gut tends to slow down. Things don't work so well. We're not so active anymore. We don't drink enough water. So that can definitely be a contributing factor. And a sedentary lifestyle definitely slows things down. So these are common things that we need to look at. Obviously, there's also other things like diseases that can play a role. And we must take that into consideration. So on average, when we see patients, we ask all of these questions to think about, is there contributing factors in their lifestyle and what they're doing that's causing the constipation, but never forget that there might be certain things, anything like if you've got a thyroid problem and you your thyroid is underactive. If you have neurological disease like Parkinson's, that's going to affect your colon and its function. You get inflammatory bowel conditions that can have an influence. So there's a number of things to consider. And I think if one's unsure whether a certain disease can play a role, you need to have that investigated by a doctor. So especially if you've got a long-standing problem and your symptoms have been going on for a while, then I think it's important to actually think about that and make sure that the necessary investigations are done. So let's just look at some of these things. Food and fluid, I think, is one of the big lifestyle factors that we must really think about. In our Western, not only Western society, I think in our modern day lifestyle, people really eat badly. We rushed, we're in a hurry, we don't eat breakfast. And then if we eat, it's on the run and it's junk food. And our food just doesn't contain sufficient nutrients or fiber to really help the gut function well. So when we start looking at how to improve the problem, you really need to think carefully about what you're eating. I generally have a fiber chart that I will send to my patients, and they can have a look at that, and then just on average, list what you eat, look at what the fiber content of the different foods are, and you can see whether you then are eating enough. A female should eat about 25 to 30 grams of fiber a day, and we get most of our fiber from fruit and veg and the fresh stuff. So if you're not getting in enough fiber, those are the easy things to think about. Can I add a bit more fruit? Can I add a salad? Can I add some veg? So really think about that quite carefully. If you have a problem with your bowel and with constipation, and your stool is not hard enough, and your fiber intake is, or your stool is too hard, sorry, and your fiber intake is not sufficient, if you don't change your diet, you're really going to struggle. So it's a simple thing that we can change, that we've got control over, and that we really need to consider. Obviously, there's a number of things that you need to think about when you look at fiber. You get soluble and insoluble fiber, and some people's guts are a little bit more sensitive. So if you have an IBS type of picture where you know your gut reacts to certain foods, you might find that certain fiber-rich foods don't agree with you. So even though it might be a healthy food, it might not be the type of food that your gut will do well with. And so remember that on average, when we give advice as a physio, if I give advice about food, it's very general. I'm not a dietitian. I'm going to tell you to increase your fiber, and it can either be in the form of soluble or insoluble fibers. And insoluble is generally the coarser stuff, the pips and seeds and grains, whereas soluble is the softer stuff that so might not have as a big effect on your gut. But if somebody has a really sensitive gut and they really struggle with IBS, they might do better to see a dietitian and get proper input to look at what you are sensitive to, what you should be eating, what you should rather be avoiding. Because if your gut is upset and it gets bloated and crampy and uncomfortable, it really isn't going to help your bowel function at all. So for most people, if they don't have that type of picture, just increasing your fiber will be good. But there are some people that need to be slightly more careful. Yes, so that's a really important component to consider. And I think fluid is the other thing. You know, we tend to drink a lot of, in my opinion, junk. Things like cold drink and soda drinks really don't help your body at all. Then we often have things like milkshakes, and a lot of milk products is sometimes irritating to people. So it's good to just think about that and make sure that you are, again, putting things into your body that your gut copes with. Alcohol definitely has a negative effect. We see with alcohol that on the one hand, it could be a bit of a diuretic, it could be quite an irritant. So just be mindful that if you have alcohol, it could have an effect. And if it's the odd glass here and there, it might be okay. But if it's on a more regular basis, it could be part of your problem. And it might be something that you really need to consider and maybe avoid. So that's food and fluid, things that we do have control over and that we really need to consider when we are trying to manage our bowels properly. I mentioned medication to you earlier. So there's many medications that can really slow down your gut and cause constipation. I think opioids is a biggie. So if you're on pain medication, really make sure that it's not affecting your gut negatively. There's also a lot of others like calcium channel blockers, diuretics, because it's going to withdraw fluid from the, or make you wee more often, so there's less fluid. And if you remember that in your gut, in your colon, the fluid is absorbed from the stool, and the longer it stays in there, or the less fluid is available, the harder your stool is going to be. Medications like antipsychotics and antidepressants is going to have an effect. Non-steroidal anti-inflammatories can have an effect and can play havoc with one's stomach. There's a lot of people that's quite sensitive to those. Drugs for Parkinson's, anticholinergic drugs, anticonvulsants, all of those can make you constipated. And then even things like supplements, like calcium supplements, some people are sensitive to that. That can cause constipation, and iron supplements is quite a common one. And this is only a few of those. You know, I think if you are on medication and if you've got a problem, it's quite important to look at that list, chat to your doctor, chat to your pharmacist, to see if some of your medication is not contributing to the problem. And I think very important, if you're on prescription medication from the doctor, don't just go and change things on your own. Discuss it with your medical professional, your healthcare provider. Some medications, for instance, antidepressants, if you've been on those things for a long time, they might be affecting your gut, but you can't just go off them. So always be careful with medication. You know, if you can, if you think it's contributing, chat to your healthcare provider to see if there's maybe a better alternative. And then stress. You know, our guts respond to stress in a negative way. If we are constantly living in our fight or flight response and we're not in our parasympathetic response, then our guts really plays havoc with our guts. And I think it's very important to remember that. Bettina had, I think, 2 of your lectures, Bettina addressed this a while back, and it's lovely to go back to those things and go and have a look again why an upregulated nervous system will affect your gut. You know, for some people it means that they get diarrhea if they get nervous and excited or stressed. Others get constipated. But stress basically has an effect on your gut, and I think we need to recognize that. For so many of us, even though we might not consider ourselves to be personalities that's anxious or stressed or depressed, we still live a lifestyle where we experience a lot of stress. Just being hectically busy, you're running around, not sitting down to eat properly. Then you're in and out of the car and you're eating on your way, or you just grab something for junk food. That in itself is enough to also upset your gut and just affect things in the way things are working. So remember that our bodies function better if we're in our rest and digest systems. That's where our gut can function. That's where our heart rate is calm. That's where we can function properly. We can concentrate. If we are literally running away from the lion, so you think there's danger and your body's got increased adrenaline and stress hormones all over the place, and your nervous system is so upregulated, your gut cannot function properly. So that is why, and you probably know that a big part of our treatment to regulate or help ourselves is to focus on breathing and relaxation and calm down our nervous systems. And it, like I've said before, it directly affects our gut function. So please consider that. I found this little cartoon and I just thought it was interesting to share, you know, where this little guy comes and asks the colon and the gut, oh, have you been keeping everything? And the gut says, yes, it all has sentimental value. And although it could be garbage and you want to get, or you need to get rid of it, you hang on to that now, and you feel that those are your memories. And I just thought that was making a joke of it, but can be quite true. We sometimes hang on to stuff and we don't realize our emotions and the way we respond to things and the way we process things can affect our guts. In order to empty properly, we have to be able to let go. So remember that as part of looking at your gut function and constipation, you sometimes really need to address the different emotions, the different stresses that you are dealing with every day. And yeah, don't forget how big an impact that can have. Um, so let's quickly chat about pelvic floor dysfunction, and then we'll stop for a moment. So part of what can influence the way our bowels function is our pelvic floor muscles. And remember those pictures I showed you earlier, the sphincters, our pelvic floor muscles need to be able to contract to give us continence, to give us support, but they also need to be able to relax well enough to allow us to empty. And if there's a problem, so if the muscles are too tight and they cannot relax, or if there's a paradoxical contraction when we try and pass a stool, we're going to have a problem. And a paradoxical contraction basically means that you sit down on the toilet, the muscles are meant to relax, but then they actually tighten up. And sometimes that could be because we have taught ourselves bad habits, because we're straining and pushing, and that actually tightens up the pelvic floor. And it's like the muscles just get a little bit confused and they almost don't know what to do. So this little picture of the dog here actually shows quite nicely what a tight pelvic floor will look like. So when a dog is scared, they put their tail between their legs and they in that position where everything is pulled up and tightened, so you can see how the back is flexed, how the whole pelvis tucks under and tightens up. And that's exactly what we see in the pelvic floor. Our pelvic floor is a muscle, just like any other muscle in the body, and it should be able to move freely. It should be able to squeeze and tighten and pull up when it needs to, but it also should be able to relax when it needs to. And when we walk around and everything is so tight and tense, imagine me walking around with my shoulders up at my ear all day, or with my arm up here all day. I'm going to have a muscle that really struggles to relax. And the same with our pelvic floors. So if you feel tense, if you feel anxious, if you are stressed all the time, what is happening in your pelvic floor? Your pelvic floor is probably like this here, all tight and not able to relax. And now you expect that, oh, I need to go to the toilet and I sit down and the muscles must relax. But that poor muscle is so tight that it really struggles to do that. So a big part of our physio treatment is addressing this and trying to get our pelvic floors to function better, to relax better. So that often the type of symptoms that you might experience if your bowel or if your pelvic floor is too tight is that you've got an abnormal sensation in the rectum that feels like it's full, feels like you want to go, but maybe it's not truly stool in the rectum. It could be that muscle being too tight that gives you that sensation that you want to go. You might find it very difficult to pass stool because the muscle is so tight that it won't relax, to the effect that some people actually have to help with their fingers to get the stool out because that anal sphincter being so tight just won't open up. And then sometimes people will try and help either at the anal opening by trying to release the muscle, or sometimes if there's a prolapse, especially just by pushing on the perineum to the sides or in the midline to try and get the stool to come out nicely. It's often very painful to pass stool because that little sphincter is so tight, and now that big stool is trying to move through, so it can be really painful around the anal area or even higher up or to the front of the vagina, that things can feel painful when you try and pass stool. And then very often it means that you won't empty. Just because the sphincter is so tight, things cannot move through very well, so you actually don't empty everything that is in the rectum. And that's typically what we see when somebody struggles with a pelvic floor dysfunction. Right, so I think, let me just see what my next slide, yeah. Let's stop there for a moment, and I'm not sure if there's any questions, Bettina, that people have asked.
I don't have any questions at the moment, but so please put your questions into the Q&As. But Hester, I think I love the detail that you're going into. Although at times people feel overwhelmed with detail, I think what's so important is that I think the majority of patients that come and see us are not, are not having this problem for a week or two. Most of the time they have chronic constipation, and it's something that they've really struggled to resolve, and it's been an ongoing thing. And I think for me, in it always what I used to always say to everyone is that, because they'd say, I've changed my fluids and I've worked on my diet, and very often what I found is that I used to say then, but have we ever done it all at the same time? So yes, fluid is very important, and diet is important, but at the same time is also important, because if we increase our fiber and we don't increase our fluid, we're actually bulking our stool up, and we're actually making it harder, okay, that could actually make it worse. But it's not worse because your diet's wrong, but you're not flushing it out with the water to get it moving. If we've got the fluid right and we've got the diet right, and we've never looked at the stress, then we get the food right, we get the fluid right, but the gut is constantly saying, no, please don't go and digest my food, because there's a lion that's going to eat me, and that's dangerous. It's dangerous for your body in a fight and flight survival mode to digest food. It's not there to digest the food, it's there to keep you safe, okay? So suddenly it's like, okay, we haven't looked at that. Then we add that component into it, but possibly there could be a medication situation that is just making everything just that much more difficult. Sometimes we can change it, sometimes we can't change it, okay? And we change what we can, okay? We don't have a perfect scenario. And then we look at that, and then suddenly we go, but have we ever looked at what's happening down in the pelvic floor? So maybe everything's starting to wake up, everything's moving, the diet's right, but the pelvic floor is so tight that we can't let the stool out suddenly. And what happens is that, and I really like to all of you listening, you hear, because you are trying to understand what's happening in this area of the body. And often what's happening is that there is a combination of things happening, okay? And we are relieved when there isn't a combination of things happening, and us advising you to increase your fluids, it makes a difference and solves the problem. That's great, but very often it's not the case, because there could be more than one thing happening. And when we're looking at that, it's almost like a domino effect. And a lot of people feel overwhelmed by, but there's so many things that could be happening here. But if we just had to do a little bit in each department, that momentum of change comes about far easier. So you don't have to have a perfect diet. You don't have to get your fluids completely right. But a slight adjustment in medication, a slight shift in, or some breathing, or some relaxation, and it doesn't have to be an everything or nothing. It can be a little bit in each department, can actually go a long way. So it's really great to just have that understanding. So thank you for the detail in which you're sharing, because it really, there is value in understanding the different components. So we do have one question here, Hester, and it says, so what if you bleed when you just urinate and also pass stools? So here I don't know if you are going to be discussing bleeding, or whether you would like to maybe speak to this now or come back to that.
So maybe let's chat a little bit about that. I mean, if you're bleeding just when you urinate and not even when you're passing a stool, you do want to think about why. Yes, what can cause bleeding around that area? If you have piles or hemorrhoids, those are little swollen veins that sit either just inside the anal opening or just on the verge of the anal opening. And if there's excess pressure, they can bleed. So often people will then bleed if they pass a stool, especially when they're straining and it's a bit more difficult. The other reason for bleeding could be a fissure. So a fissure is a little tear in the sphincter or the skin around that area of the opening. That can certainly cause a problem. And again, mostly associated with passing stool. So why would it happen when you're urinating? Interesting question. One wonders whether that person is perhaps straining, because if you cause pressure into that region, that can definitely be a contributing factor. Bleeding, and I think one needs to maybe clarify also where the blood is coming from. Sometimes if you are urinating, you could have blood in your urine, and that's different from blood around the anal passage or blood in your stool. So one must maybe also just think about that. And if it's an ongoing problem, I would have that investigated. One of the signs or things that we don't like is lots of bleeding when we are passing stool, because bleeding can be a sign of something going wrong. It can be a sign of cancer, for instance. So if there's ongoing bleeding, it's certainly worthwhile having that investigated, and doctors can do a scope just to make sure that there's nothing sinister going on, and that it might just be one of these other contributing factors. And it also depends on how much it is. If, for instance, you bleed, if you have a hemorrhoid and it's because of the pressure of something coming through and the hemorrhoid pops and it bleeds a bit, but it stops immediately after, that's probably not dangerous. But if you have ongoing blood loss and it's quite a lot, then you obviously need to think about that, because that's not healthy for the body as well. So bleeding is something to think about. I think, and the fact that it happens when you're urinating is makes one wonder about pressure in the area. I don't know what your view is on that, Bettina.
I agree with you, Hester. And so there's been a follow-on comment on that saying it's not in the urine, which speaks to a anorectal dysfunction. So basically there's something happening in the back passage, and it's something that needs to be, the question is, what is happening? Okay. So first you want to just know that there's nothing ominous happening there. So that's step one. Okay. The next step would be to identify what is happening. So like you say, the conditions that cause bleeding. Okay. And each of them speaks to a slightly different way in which the bleeding occurs. So, and usually in that area, it speaks to pressure in the area. So it's almost like you're popping or irritating, or so, you know, that we would speak to that with hemorrhoids, or we speak to that with fissure. We would speak to that with mucosal prolapse, okay, which is kind of where the mucosa comes down a bit. So these are the types of conditions that can cause bleeding. The fact that it may be bleeding with urination speaks to me, and I would assess that and look at that in this system is really irritated. That even just so the first question I would ask is, are you pushing when you wee? Okay. Are you straining when you wee? And I would also speak to, how are you wiping or cleaning? Or because often what happens is that we irritate, so we constantly like picking the scab, or you know, the area is vulnerable and sensitive, and we really want to stop irritating the area, be it through any level of pushing, be it through a lot of physical activity. Sometimes can, you know, if you're jumping or you're on your feet all day and you've got hemorrhoids, and you know, it's just, there's this constant pressure. You know, it speaks to how we toilet, and it speaks to how we tend to that area during and after toileting, you know. So all of that could be, and very often when we allow the area to heal a bit in that sense, maybe just, let's say it's a wiping thing, and if we had to just dab or not wipe, or you know, use water and not actually cause any friction, you know, that could be enough to resolve the problem with urination. But I would but any form of pressure and pushing and irritation can and will irritate a very sensitive, you know, it just shows me that this area is very irritated, is what I'm reading into that. And we're happy to discuss anything further if you'd like to elaborate. Hester, there is one other question, and before I'm going to let you continue. So is colon hydrotherapy healthy? And if it is, how often can one have that?
Yeah, so I think
smile because it's a debate that we've had in the unit,
absolutely,
in the colorectal unit, for years and years.
Yeah.
So thank you for this question.
Because I think depending on the healthcare practitioner that you go to, they will probably give you different opinions on that. I think for people that really, really struggle to empty and that feels that they get backed up quite a lot, it can be helpful in the sense that it does help them to empty. And I know we once had a presentation from a lady who does colon hydrotherapy, and she did say that part of what they try and do is to also retrain a person's bowel to be able to work better on its own, because I think ultimately that is what you'd like to see. you don't want to start relying on things that could maybe cause your colon to then function in such a way that it also becomes reliant on only that, because then you're going to have to be repeating that over and over again. It's a bit like using laxatives. So I think there's a place for colon hydrotherapy. I think each individual should be looking at their symptoms, their specific problem, to see if it can be something that helps them. And how often one can have that, I suppose it depends again on the problem. I'm actually not sure. I'm trying to remember back to what that lady told us, how often they advise it. And I can't remember, but I don't know if you were at that discussion either. But
Yes, I wasn't.
Yeah.
My memory of all the repeated discussions on colonic hydrotherapy is that we were created in a way where the colon knows how to empty itself. And the question was to why do we need that level of invasive intervention? And that was my takeaway from the discussions, unless we've moved past that by now. But and I also I understood there to be risks attached to it, and that if the system is well managed, there should be no need for hydrotherapy. That was my understanding from the discussions we raised in multidisciplinary teams at the Fitz-Donald Gordon over the years with various colorectal surgeons and professionals. So I don't think that we really have the answer to that.
That you should or start doing. I think you should really look at what is contributing to your problem before you can consider something like that. And like I see we've got a comment there, somebody who had bleeding stools, and yes, that could be rectal cancer, and important to check that out. Yeah, I'm not sure if that's necessarily related to the colon hydrotherapy, but yes.
And I think that's we tend to see these conditions on the back end of, so people are referred to us, and invariably, like yeah, we invariably we know that there's nothing ominous, and there's nothing else happening there that is not managed with conservative care, because at the end of the day what we're doing is more conservative management, so
Absolutely.
And then there's another comment. The only thing is I might miss some of these in the chat. I'm going to try my best, but please pop your questions into the Q&A so that I don't miss anything. But there's a comment about, is chocolate really a constipation? In fact, I thought it made mine loose.
Yeah, it's always interesting to just know that people are different, man. Everybody's gut respond differently. So some people might be lactose intolerant, or they might have a sensitivity to certain dairy products. And for some people, yes, it can cause a loose stool, but for others, it can constipate them. So again, I think you need to look at your gut and how you respond. What type of chocolate are you eating? If you have chocolate with loads of sugar in it, that in itself also has an effect. Some of your darker chocolates supposedly contains antioxidants and might be was said to be better and not have such a negative effect. But I think people are different, just like some people can eat coarse fiber and be okay, others can't. So look at your own gut and see how it reacts to certain foods.
So I just have one other comment about the possibility of subtitle captions with the recordings. If so, now you are asking my for tech skills that I may not have. So if you are able to assist me, I will do my homework on that. But if you're able to tell me how that's done, I would really value. You can email me, and I would really value that education. So thank you for that comment. That's something I've never thought about. So thank you for mentioning that. Thank you for that.
And something else also, I don't mind. I can share my presentation in a PDF format to people afterwards. So, you know, if we've got your email addresses, we can send it to you, and then you've got that in that format as well.
And maybe Hester, you can send me that because everyone that has, you know, all of you and anyone who has registered gets the recording.
That's right.
And yeah. I will forward the PDF with that, and that will be great. So Hester's happy to do that. Thank you.
Yeah.
All right, Hester, let's maybe let's carry on, and then we'll pick up some extra questions and just pop them into the Q&As for me, and we'll pick them up shortly.
Perfect. Right. So we talked about pelvic floor dysfunction. Sorry, let me just get this going again. There we go. So I'm going to chat a little bit about what we as physios can do to try and help somebody with constipation. And those of you who are my patients know that we spend quite a bit of time on breathing and talking about the connection between breathing and the pelvic floor, and then constipation ultimately. So just remember that our pelvic floors are part of the core muscles, other core muscles being diaphragm, abdominal, and lower back muscles, and those four muscle groups work together. So if we have an incorrect breathing pattern, if we hold tension in our abdominal areas, if we have back pain, or a pelvic floor dysfunction, these four muscle groups really work together. If you're not breathing well, your pelvic floor is not moving optimally. If you have tension in your abdominal area, if you have scar tissue maybe that might be causing tension, or muscles that's in spasm that might be causing tension, it's going to affect how the rest of the core works. So one of the first things that I really want to start doing when people have a problem is to look at their breathing pattern to ensure that they are not breathing in a way that might put pressure downwards into that pelvic area, especially if they've got a prolapse. Our breathing and the way we breathe should be soft and gentle and easy. And if we breathe well and our diaphragms are moving properly, our pelvic floor can respond so much better, and that enables our pelvic floor also to relax. So breathing is really one of the corner foundation keystone things that I want to have a look at and start with when we are treating this type of problem. So I think there's more than one reason to look at how we breathe, but the one is to teach people how to be able to relax their pelvic floors and how to move their pelvic floors properly. So remember that when you're breathing in, your diaphragm descends to allow the lungs to fill with air. The other core muscles, so abdominals, lower back, pelvic floor, should respond to that, and basically they should relax and allow that diaphragm to move downwards. If I'm breathing and I have got a tense breathing pattern where I hold tension in my abdominals and I suck my tummy in when I breathe in, how on earth is my diaphragm supposed to move down? You know, because if I breathe in and I tighten my tummy and I pull in here, all the breath goes up here. That's not an optimal way of moving either my diaphragm or my abdominals or my pelvic floor. In reality, we want to see that this is the diaphragm and this is the pelvic floor. As I breathe in and my diaphragm descends, my lungs fill with air, my pelvic floor should drop gently. And as I breathe out, so they move like this. Okay. And so many times we see people when they're anxious and stressed and they're running around and things are hectic, that they breathe very shallowly and they've got this tense breathing pattern where they're sucking in their tummies, you know, and then we're told to pull in our tummies and stand upright, which just further almost contributes to the problem. So we don't have good mobility in those muscles and things are way too tight. And if we have got an upregulated system, and things are like this, nothing can work well. So by breathing well and just getting the diaphragm and the pelvic floor moving in a synergistic manner, we can really already help our pelvic floors relax a lot better. And I think one of the first things that we need to make sure of is that when we have a pelvic floor dysfunction, and that means it can be weak, it can be tight, it can be a combination of the two, we need to just consider how our pelvic floors move and how that affects the problem that we have. So in general, with constipation, it's tension in the muscles that prevent them from relaxing well enough. But we could also have quite a weak pelvic floor in somebody with prolapse, where things are not supportive enough, and then it also doesn't function well when you try and pass a stool. And sometimes you've got a bit of a combination of the two. So one of the misconceptions that we often see is that people are told, oh, you've got a pelvic floor problem, you need to do Kegel exercises. And I just want to stress that one really needs to firstly think about what type of pelvic floor problem you've got, and that Kegels are not the answer to every pelvic floor problem. So a Kegel exercise, generally, when you look at it, is regarded as a strengthening exercise where people will focus a lot on squeezing and tightening and pulling up their pelvic floors. And that really is only half of what the pelvic floor should be able to do. Your pelvic floor should also be able to relax and let go. And therefore, if you are doing a pelvic floor exercise rehabilitation program, you should focus on both those aspects. So there's obviously a balance. It needs to be strong, it needs to support, but it also needs to be able to relax. So a lot of the time when I start people on a pelvic floor rehabilitation program, I'll first just look at movement and get that pelvic floor moving well, together with a right pattern of breathing, ensuring that it can contract well, but that it can also relax properly. And then, if necessary, and it's really weak, we will think about strengthening. So a lot of the times we actually look at reverse Kegels if people are too tight, and teach them how to relax and downtrain their pelvic floors, move it properly with the breath, and not just a typical strengthening exercise program. But I think, remember that that's important. You need to have your pelvic floor assessed by somebody who can look at the muscle function before you actually just assume what type of exercises you need to do with your pelvic floor. And for me, you cannot move your pelvic floor well if you are not breathing properly. So we come back to that. So I think just remember that. And if you have a pelvic floor problem, make sure that you see a physio that can address that, can assess that, and teach you the right way of breathing and the right way of moving your pelvic floor, depending on what you are dealing with and what your body is like. So let's just look at some of the other things besides the pelvic floor that we can do to help our constipation problem. And I think the simplest things are the ones that we should address first. And those are the things that we've discussed before. I think we've talked a little bit about look at water, look at fiber, look at exercise. If those three things are not in place, then adjust it. Drink more, eat enough fiber, the right type of fiber, get moving. Unfortunately, I think our lifestyles nowadays, we sit a lot. We sit in front of computers and we don't move enough. And then we sit in front of the TV and we sit in front of our devices. So get moving. It can be as simple as that to really just help your gut move a little bit better. Yes, if there's illness present, let's treat that. The doctors will help you. They will do the necessary investigations. Like people with a prolapse, for instance, they might need some investigations. But your first route of therapy, again, should be the conservative. And if that doesn't achieve the desired result, together with the right medication, if it is necessary, then you might need other types of treatments like surgery. But let the simple things be the ones that you try and change first, because often that can really make a big difference. Know what you should avoid and what you should be careful of. Know what affects your system badly. Like I said with IBS, if you react to certain foods and you eat the wrong stuff, you're going to have a problem. So one should be mindful of that. And sometimes, it's easy to say avoid certain foods, but sometimes you really need to look into that and actually do a bowel diary and try and figure out what is the food that's affecting you. Because for some people, again, it's not just a simple thing. You might find that I eat a little bit of this, but then I skip breakfast and I've got a really stressful day, and then I eat too much junk food, and suddenly you've got a problem. It's also often not just one thing. It's one and then the other and then the other. So it sounds simple to say that, and I know it sometimes can be quite difficult, but it is an important component. And that's one of the reasons why I spoke to a dietitian colleague of ours, and she will do a lecture for us on diet and the effect of foods and IBS, because I think there's a lot going on in our guts that she can really maybe chat to us about and help us understand that better. So that will hopefully be one of our next talks that we will then also have a look at. But yeah, so look at the basics, see what you've got control over, what you can change, and then if that's not working, one can look further. What about medication? So often people walk into our rooms and they've been using laxatives for many years. And I think one must realize that if your bowel is used to using a stimulant laxative, it really becomes lazy. It gets used to that, and you often see that people then have to use more and more, and it doesn't really solve the problem. You just have cramping and diarrhea in between of bouts of constipation because your gut is not functioning the way it's meant to. So we're a little bit careful about just going onto laxatives. Sometimes if you've done the basics like the water and the fiber and the exercise and you're still struggling a bit, then you might need a bit of help with medication. But I think we also want to use the things that's safest and that doesn't have side effects. So certain stool softeners like Movicol is one of the things that our doctors prescribe quite often, and they're pretty safe to take. It just draws water into the stool, so it makes your stool a little bit softer, and for a lot of people that can really already help a lot. So if you are struggling, you've tried the diet and you really are trying to drink a bit more fluid, and you're still not getting that stool consistency to a type 4, then you might want to think about adding something like that. So remember, it's not a stimulant laxative. Stimulant laxatives are things that contain senna or aloe, and there's some other stimulants, but those are the things that will cramp you and eventually actually give you diarrhea. You don't want diarrhea. You just want your stool to be a little bit softer, to move through the gut a bit easier and enable you to empty better. You could also think about fiber supplements. So fiber supplement can be something like psyllium husk or fiber gel or Benefiber. And those basically just add a little bit of fiber into your system because that will help the food to move through the gut better. Remember that fiber is like the broom. It sweeps the food through the gut and help it move through. So if your fiber is too low, then things tend to be slow. So a fiber supplement can be something safe, something easy to use. But if you add fiber in the form of a supplement, you really also need to drink enough water. Otherwise, you might bulk things up a little bit too much. So fiber is a bit of a regulator. You know, if people have constipation, it could help to move things through a bit quicker and soften the stool slightly. And if you have diarrhea, fiber can sometimes help to bulk things up a little bit, to just not have that very loose stool. So we would try those two type of things first before we actually resort to stimulant laxatives. They should almost be the emergency situation where other things are not working. And I think also important if you're looking at that to maybe get the opinion of a medical practitioner when you really, especially if you're using that long term, it's not the ideal. One would like to wean patients off that. And having said that, if your gut has been used to laxatives for 20 years and you suddenly just stop it, you might be in a bit of a fix. So also be careful with how you adjust. You know, generally then one would suggest, let's start, add the others, add a bit of Movicol, add a fiber supplement, and slowly, if your gut function improves, we can wean you off the laxatives. Obviously, in the ideal situation, one would like to be able to not use laxatives at all. Things like enemas can be used to help one to empty, but again, I think shouldn't be our first choice. You also get suppositories like glycerin suppositories, and there's some other suppositories that one can use if you're really stuck and you just feel that things are there but it doesn't want to come out. You could use that, but again, I think you don't want to use that all the time because our bodies get used to that and then they don't want to function on their own. So medication can play a role and can be helpful, but shouldn't be, or hopefully, I think in most cases we don't want to be using that all the time. So just be mindful of that. I think we've talked about fiber and food, and this is just a slide to remind you there's just some general suggestions. Again, just remember that each person is different. Some things work for some people, it doesn't work for others, but these are the common things that could be good sources of fiber. If you have IBS and you have a bit of a sensitive gut, you might not be able to use all the insoluble fiber. So just remember that. Natural things that we can try and simple things that can work for a lot of people besides drinking a bit more water is thinking about something like prune juice, which is a little bit like an osmotic laxative and will help to soften the stool and initiate peristalsis. Things like applesauce and oat bran can really be helpful and easy to add to one's diet. So there's just some suggestions on that. For some people, it really works to use a smoothie. You know, smoothies are quite, almost want to say, fashionable these days, but it can be a lovely way of introducing more fiber into your system. And it's quite pleasant, in fact. Like a green smoothie, a lot of people, you tell them about that and they're like, ooh, that doesn't sound pleasant. But if you make a green smoothie with an apple base or a fruit base, and then you just add your spinach, and if you're not sensitive to lactose products, milk products, you can add something like yogurt, or you can use milk, and then banana and pineapple. Apple, I find, are good with that. The chia seeds is a lovely form of fiber, bit of honey to sweeten it, and some people like to add lemon juice and a bit of ginger to that, and it's actually got a lovely taste, and it's something that can help to get the gut going. So remember that things like this could be easy. Other things that can really work, remember that coffee can be a stimulant for the gut. So if you're not sensitive to caffeine, you can use that. A lot of people will tell you, I have a bit of coffee in the morning and I get the urge to go. Or otherwise, hot water, warm water with a bit of lemon can be something that early in the morning can get your gut to work. We haven't really talked about timing. So if you think about, before we go into the abdominal massage, if you think about how your gut works, your gut peristalsis is most after a meal. So 15-20 minutes after a meal, and especially after breakfast in the morning, might be the first urge sensational message that you will get that your tummy wants to work. So for a lot of us, you look at your morning, you're rushed, you have to get the kids to school, you don't have time to eat properly, so you really don't help your gut if you're constipated. And we need to think about that a little bit. If our gut sometimes just needs a little bit more attention, you might have to get up a half an hour earlier, just be less stressed, less rushed, eat breakfast, drink something warm, and allow 10 minutes or so that you can go to the toilet. Because if you might be like, oh, I need to go, but no, the kids have to get to school. So now you rush off and you start your day and you haven't gone. And then you might not get that urge until later today or tomorrow. And then the stool is going to be a lot harder. So also just remember timing, and that our bowels like to work in a certain way, and you need to recognize what works for you. Doesn't mean that your bowel has to work in the morning. So I'm not saying get up and after a meal go and sit on the toilet and now start pushing because you want your gut to work and you think it's the best time. No, you must also listen to your body and listen to your messages. If you get everything right, so if you have an urge and you know that's the time I need to go to the toilet, your stool is soft enough and you can sit down, then things should be a lot easier. But listen to your bodies. So these are things that we can try and help our guts function a little bit better. Something else could be an abdominal massage. So it's a simple thing that everybody can use at home. It can be done to stimulate the gut peristalsis. And it can also, an abdominal massage can be a really, really nice way to actually down-train your nervous system a little bit and make the body a bit calmer. So initially, you might really do it to just try and get that gut to work a little bit better. But remember that it can also have other positive side effects. And generally, what we will tell people is to start with circular motions, massaging around the navel area. Remember that your small bowel lies there and the food moves from the stomach into the small bowel first. So if you start around the navel and you make little circles around using your fingertips, some people like to use their palms, whatever works for you. And then you slowly but surely make your circles bigger and bigger and bigger to cover that whole area of the small bowel. And eventually you're going to land up at the colon. So if you look at this picture here on the right, remember you've got ascending, transverse, descending colons. So you continue with your little circles all around. And that could take you, oops, there we go too, sorry. That can really take you 2, 3, maybe even 5 minutes if you want to spend that much time. And after you've done the circular massage, we then do a massage that we call the I love you massage. And it's a bit of an upside down I love you. The I meaning that it's this action, where you start sweeping down your descending colon, emptying it out. So you're just doing that motion from the top at your rib cage, emptying the descending colon, because that's the last little bit where stool is, and you need to empty that out first. So you do, let's say 10 strokes down that right-hand side of your body. Then you do the L, which is across the transverse and down the descending. So it starts from your right-hand side of the rib cage, across that transverse colon, and then down the descending colon. And you can do 10 repetitions or so of that. And then you do the U, which is again upside down U like that, up the ascending, across the transverse, and down the descending colon. And that can then often just also help to get things moving through the colon and try and help with emptying. So abdominal massage can be a useful tool. And then I'm sure all of our patients know about how to sit on the toilet. Such a simple thing, but that can make such a huge difference. For some or other reason, it's not something that we talk about and that we necessarily train our kids, maybe unless you're a pelvic floor physio. But it really is something that we should give more attention to, because the way we sit and what we do when we're on the toilet is going to make a huge difference about how well your muscles can relax. So the optimal position is one where we're trying to imitate a squat. And remember, it's about trying to get that puborectalis muscle to relax properly around the anal opening. And puborectalis can relax a little bit easier if we in a squat. So our toilets don't allow us to squat, and I'm not telling you to actually squat on the toilet. I've seen interesting pictures that people do. It's simple enough if you just get a little footstool or something under your feet to raise your knees above your hips. That's really what you want. So just that slight little bit, if you look at this picture, person's got a little footrest there, and you can literally use books, a box, bricks, toilet rolls, anything that you've got in your bathroom. It doesn't have to be a footstool. Put your feet on top of that. Then make sure your knees are a little bit higher than your hips. It doesn't have to be too high. You know, ultimately you need to be able to relax and be comfortable. Some people with back and knee problems might not find it comfortable to have their knees too high. So be mindful of that. A nice comfortable position. And then you want to sit there, open up your knees a little bit, you know, don't close your knees and keep them together. Keep them slightly more open. Lean forward, rest your elbows on your knees, and not pointy elbows like this. Nice and soft. And then make sure that your spine is straight. If we strain, what do? We literally go, oh, and we curl up and we tighten our tummies, and our backs are all rounded, and that just tucks your pelvis under and tightens up your pelvic floor. So that's really not the way to try and pass a stool. So you want to lean forward, gently breathe into your stomach, allow your stomach to now hang, be completely relaxed. And that takes us back to understanding how to breathe properly. And if you do that, and you can sit down and relax, and your stool is soft enough, things should happen on its own. You should not need to strain at all. Our peristaltic action of the gut should actually be enough to push that stool out gently. It's not an action of pushing that. It should be quite gentle. So that's toileting position, and it's simple and really effective. I think it's one of the things that people come back and they say, wow, that really makes a difference. We know that in some cases, if you, for instance, have a rectal prolapse and your anatomy has been affected, that it might not change things completely because you've got a prolapse, but it can still make a difference. So think about this. This is an important one. And then if we do need to add a little bit of pressure, and I always say that pretty carefully, there shouldn't be loads of pressure when you pass through, but sometimes there's just that little bit that you need to add to get things moving. Then we can use this technique where we breathe our stools out, really. We call it abdominal bracing or bulging, where you actually gently breathe into your tummy and your tummy becomes bigger. And then you gently close your glottis and you go, so in other words, you breathe in, close your glottis, and gentle pressure like that, but you make your tummy wider. Your stomach should grow bigger. The moment you pull your tummy muscles tight and you pull in, you're not going to allow the anal sphincter to open. That closes it. And then you're pushing against the closed sphincter. So you want to breathe into that belly and allow that belly to gently move to the sides and become bigger. And that slight pressure can help you pass a stool. I think it's important if you try this technique that you be taught by a physio, because you can easily think that you're doing the right thing and then sometimes you're not. So if somebody looks at you and put their hands on your waist and they can feel what you're doing, it's a lot easier. My next slide, I think, yeah, it's got a video on that I'm not going to play now because we're running out of time, but it's called Moo to Poo, and she shows you how using sound, so like that what I explained to you on the previous slide, if you breathe in and then you go like moo or shh, and using that sound often will get the muscles to open up and relax instead of tense up. So that can be another useful way. It's really the same principle. I haven't actually shared the link here, but it's on one of my other slides, the same video link that you can go and watch on YouTube. It's quite useful. She takes you through the motions. Useful to go and practice. Right. So there's the link with the different videos that you can have a look at. And some is on straining to the kiddies. It's this guy talking about a cone of ice cream, and he shows you how it works and it relates to the bowel. So it's just nice. I think those things can be really helpful. And the last couple of slides, or the last 2 or 3 videos, have got some suggestions for exercise, because I think that's another component, and I've briefly just mentioned it here, that besides our specific pelvic floor exercise and pelvic floor movement, you can also add other exercises, especially if you've got tightness in your back or your abdominal muscles or around your hips. Then different stretches, different types of exercises can be useful to also help your bowel. So don't forget those. Again, I think important to make sure that you're doing things in a proper manner, that you're not doing anything that could hurt you. So if you've got a lower back problem, don't just assume that this is a good exercise. You need to do it correctly, and it should never aggravate your pain. But exercise is an important component of trying to address this sort of problem. And certain yoga positions and yoga poses, I don't have that on here, can really be helpful. So there are things that we can do. I personally really like child's pose. So child's pose is that position where you lean forward, and this specific person, I generally get my patients to keep their feet together, knees apart, so that you really open that space. You can drop your tummy in between your knees. And you can breathe into your tummy, and you can open up that pelvic space. It's a lovely position to just help you understand how to relax your pelvic floor. But a lot of these others then can also be helpful. So those are other things that you can try besides walking or some other cardiovascular activity that will help to stimulate your gut. And then I just have a last slide on here about other physiotherapy treatments where you can use machines or biofeedback or EMG to try and help you with passing a stool. So I find that personally I do a lot of manual feedback using internal examination, guiding somebody with my finger pressure or what we're doing in terms of that. And I think that is as effective as using an EMG machine, but there are these options where you use an internal probe, either vaginally or anally, connect somebody to a machine, get a reading of what their muscles are doing, and then that could be helpful as well. So one of the tools in our toolbox. A lot of the times our doctors will ask for biofeedback as part of the physiotherapy treatment. And I think they often refer to this, but manual biofeedback can be just as effective. So that brings me to the end of what I'm sharing with you today. There's probably a lot more, and we can keep on talking for hours. But I think let's look at the simple ways we can help ourselves. There's really often a lot of things that we can do. Fluid, fiber, exercise, managing our stress. So releasing tension in our pelvic floor muscles, breathing properly. Those are the basics, Try that first and see how things go. And if that doesn't help, then we look further. So I hope this has been helpful and that you can take something away from this. You're welcome to contact us if you feel that you have more problems or you need a little bit more help, then please contact us. I'm sure most of you do have our contact details if you need that. But thank you for allowing me to chat to you for a while, and I hope that you found that helpful.
Hester, thank you so much. That was so valuable, and I really appreciate all the, you really gave such a thorough overview and all the extra go-to videos. And I think, we are in a time where we are needing to, we all pressured for time. There's financial pressure, there's many different pressures, and we spend so much time in our sessions going through these types of things that if you can start to look at this and do kind of all of that prior. It just allows us to almost hit the ground running, and just thank you for all your time and your efforts. And if there are any other questions, now's the time.
People are welcome to ask.
And there's just lots of thanks and gratitude to you, Hester, for that presentation. But otherwise, it doesn't look like there's anything else that's coming forward for now. But Hester, thank you so much. Thank you for your time, and I will definitely hold you to that dietitian discussion, because I really. I think it just allows us to elaborate and go into that, because we eat every single day, but it's not so easy to really know what is good and what's not, and so if we can chat further on that. So thank you so much, and thank you to all of you for being here.
Yes, thank you for attending and listening.
And we shall pick up at another time. So thank you and good night.